afternoon, everybody, and welcome to today's meeting of the West Yorkshire Health and Care Partnership Board. Thank you, everyone, for giving you time to share this meeting with us. We talk about the overall approach to how we join up services and support and invest in meeting the current and future needs of people in West Yorkshire. Today's agenda includes a report from Rob, the partnerships lead, a report on our ambition to increase our early diagnosis rates for cancer, and a second report on our ambition to reduce the gap in life expectancy for people with mental health conditions, learning disability and autism, and a paper on the real living wage review. I realise I forgot to introduce myself properly and say my name's Tim Swift. I'm the chair of the partnership and also a councillor in Calderdale. I know we've all done lots of these online meetings by now, but we can just ask people to mute microphones when you're not presenting or speaking. When people are speaking, really good if you've got camera on so we can see you, and invite people to introduce themselves and say where they're from when they're speaking. If people use either the raise hand or the chat function, I'll try to make sure I see you and bring you in, and I'm sure somebody will prompt me if I miss anybody. So item 2, we provide an opportunity for questions and deputations. We haven't received notice of any public questions today. So I'll move us straight on to item 3, which is declarations of interest. Obviously, it's important that any conflicts of interest are properly recorded and declared. We will all have completed declarations for our own organisations, and they help to form part of the record for this meeting. But if there are any specific interests in relevant items on the agenda, then I would urge people to declare them when they arise. Item 4 then is the minutes and the action log from the last meeting. I just wonder if I could ask people if there are any points of accuracy or any points anybody wants to raise in terms of outstanding actions. I'm not seeing any indications. I'm not sure anybody from the team has any comments on the action log at all. No, again, I'm not seeing anything. So are we then take a... oh, sorry, Kathy, thank you.
Thank you, Councillor Swift. Good afternoon. Hello, my name's Kathy Elliott. I'm Chair of NHS West Yorkshire and Deputy Chair of the Partnership. Tim, I just wanted to share that when we had our discussion in March on climate change strategy and receiving an update from Frank Swinton, who leads on the strategy for the system, he has subsequently last month held a chairs and leaders session, which I know a number of colleagues here attended, to bring the strategy to life. We heard from an example in Wakefield of how the strategy has come to life for Mid Yorkshire Trust and colleagues within the place system. So I hope that information was helpful and that session was helpful. And if anyone's got any questions, we can send some information on afterwards. But I don't think there's anything to update on the action log if my colleague Laura Ellis and others haven't come through yet.
That's great. Thank you very much for that, Kathy. OK, thank you. So I'm taking it that we are happy then to approve the minutes, and I'll move us on to item 5, which is our update from Rob Webster. Rob.
Thanks, Chair, and hello, everybody. My name's Rob. I'm the Chief Executive of NHS West Yorkshire and the Lead Chief Executive for the Integrated Care Partnership. It's good to see so many of you here today. So you've got a fairly extensive report, which I don't intend to go through in detail. I'll just draw out some points of emphasis. I think the first thing to say is congratulations to all of those who've been elected, re-elected in recent elections, whether that's local councillors, the mayor or MPs. And that signals a change to some of the political leadership, which will impact our partnership. And I think the key point I would make at this juncture is that this political change is happening at a time when we have signed off our plan for the rest of this year. financially and operationally in the health system. We have set budgets in all of our councils with the priorities that we want to achieve for this year, and we continue to make significant progress against both of those. So in the health system, things that the public deem incredibly important, like reducing the time people wait for hospital appointments, the time they're seen in A&E, the pace at which an ambulance will turn up to pick them up, having somebody to support them at home. All of the targets on those are progressing really well. And we continue to make significant progress, and we'll continue to do so because the political changes that have happened, which may impact around our future plans, we don't know what those changes are yet. So the first thing I would say for this partnership is we continue to make progress on the things that matter to local people, and we continue to progress the plans that we've already signed off. Where we see changes coming down the track, again, we are well set up, I think, as a partnership to respond to those. Colleagues will have seen, since I wrote the report, further detail about the Secretary of State for Health, for example, announcing that there'll be 2 significant pieces of work happening in fairly short order. The first is for Professor Aradazi to do an assessment of the issues affecting performance in the NHS to report probably by September. And the second, a 10-year plan for the NHS and the care system and broader we would all push for, which will be overseen by Professor Paul Corrigan and Sally Warren, formerly of the King's Fund. So those 2 pieces of work we haven't seen the formal details on yet, but I think we would all want to be a part of those and to respond appropriately when the work's done. My expectation would be that any 10-year plan would really start to have an impact in 18 months' time, in terms of the time it will take to be co-produced, to deliver some expectations. So really motoring in 18 months' time. And what we'll need to do between now and then, I think, is continue to build a bridge between the current state of affairs and the future. We are really good at that. And if you look at the 4 purposes of an integrated care system, many of which we're discussing today in the main part of the agenda, our focus on health inequalities, the variations in care, delivering value for money and impact for the citizen and taxpayer, and getting the biggest economic return on investment that we can. Those things are all positive. And the assessment of the manifesto of the government coming into government is that much of the work that they intend to do is squarely in line with our joint forward plan and our strategy. So I guess there's a first fundamental message, which is we're probably in a reasonable place to respond to anything that's asked for us. Until we're clear about what that might be, we are continuing to get on with the things that really make a difference. A couple of other things to highlight in the paper. We are refreshing the work that we've been doing over the several years on race equity. And Fatima Khan Shah, who's on the call, will be hosting a meeting in the autumn to look at where we've got to and what we do next. It's been a standing item for us as a partnership, and we continue to see it as a fundamental part of what we do. I also wanted to make sure that we recognise the significant work that we continue to do with our combined authority colleagues. There will be a requirement to produce a local growth plan for West Yorkshire under the mayoral authority with local authority partners. And we know that the health and care system, with 100,000 staff, £5.5 billion worth of expenditure each year, is a fundamental part of the economy. And one of 2 signals of that in the last week, just to highlight, which exemplify that. So the first is that we've recommitted to our memorandum of understanding with the Association of British Healthcare Industries. and the associated health tech cluster, which brings together academics, businesses, the health and care system to try and invent, adopt and adapt technologies which will improve care for people and at the same time will drive economic growth. And the second is that yesterday the Mayor and I co-chaired the first meeting of the Creative Health Board for West Yorkshire, which brings together the creative industries with the health and care system to look at how we bring together all the brilliant work that goes on in West Yorkshire, which will help support prevention and the recovery of people, whilst also supporting the creative industries. Final thing I'd say is that we've got some new people on the call today, and we've got some people who have left us or will be leaving us and announced that they're leaving us in the next few months. So wanted to thank people who've come into the partnership in different roles or stood aside and back into their old roles. So thank you to Mel Pickup for all the work that she's done, and for Therese Patton for picking up the Bradford Place lead. Thank you to Tom Reardon for all that he's done for this partnership and for the City of Leeds. He'll be leaving his post by December. Thank you to Selina Armstrong, who's joined us as Chief Executive. Selina Douglas, who's joined us as Chief Executive Leeds Community Healthcare, and various others who've joined the partnership. There's plenty of other material in the paper for us to discuss, and happy to do so. Thank you, Chair.
Thank you very much, Rob. And just drawing together your first and last item and endorsing your welcome and best wishes to the joiners and leavers, and perhaps also particularly congratulate Councillor Fenton Glynn, who was one of Calderdale's reps on this group and is now the MP for Calder Valley. So hopefully that's another voice understanding the importance of health and care integration in Parliament. So can I invite any questions or comments on Rob's report and issues raised by it? Yeah, Fiona.
Thank you. I'm Councillor Fiona Venner. I'm the Executive Board Member for Equality, Health and Wellbeing at Leeds Council, and I chair our Health and Wellbeing Board. I just wanted to home in on a really particular part of your report, Rob, which was around modern slavery, just to highlight something that I know we're seeing quite a lot of across the region and that I've come across personally in Leeds through my surgery, of people who are coming here on dodgy visas to work in health and social care, having paid a huge amount of money to get the visa, and then when they get here there actually isn't any work for them. They only have 60 days to get another sponsor, which has proved really impossible. It's literally leaving people destitute. So the two people I've had contact with, I've met at food banks, who are destitute, who've brought their family with them, who have no means of providing. And I understand this is actually quite a common theme, and it's happening quite a lot across the region and nationally. So I just wanted to flag that up.
Thanks, Fiona. Jen Connolly, can I come to you next?
Thank you. Jen Connolly, Associate Director for Improving Population Health, and I work jointly between West Yorkshire Integrated Care Board and West Yorkshire Combined Authority. I just wanted to highlight that since we contributed on the Combined Authority updates, we've actually this week the Mayor's launched two key transport engagement activities. Firstly, on mass transit, the trams coming to the region, and also the local transport plan. So those are both now live, and it'd be brilliant to get engagement from partners around this table, because we fundamentally understand the significance of transport in enabling our population to move around, contribute to growth, keep active and all the rest of it. So really welcome contributions. We will have an update on the local transport plan at the next partnership board meeting, but people can contribute through the means that are very kindly being posted in the chat. Thank you for colleagues doing that in the meantime. So just wanted to highlight those. Thank you.
Thanks, Jen. That's really valuable, and I'd also add, we shouldn't ignore the importance of of access to health appointments and health settings as well, particularly as we move more things out of kind of central locations. It always used to be a little bit of a joke, but not really a joke, when I worked for Age Concern many years ago, that whenever you did a consultation with older people about health, you ended up talking about transport. And it, I think sometimes we tend to forget just how challenging it can be getting to some of our sites as well. So I think getting that integration would be good. I'm not sure, just coming back to Fiona's point about the modern slavery, and that's certainly something I've certainly been aware of stories about, perhaps not had direct experience of it in a Coldale setting. I'm not sure whether Rob or Kate, whether other than recognise it as an issue, I'm not sure whether there's anything collectively we're in a position to try and influence on that, or any thoughts on that.
So definitely one for us to think about in 2 dimensions, and it might be that Louise might want to talk about the second of those, and very happy for Kate to come in as well. So the first dimension is, trying to prevent this from happening in the first place, and making sure that we use the mechanisms that we have at hand to ensure that any agencies or institutions that are going down this route face the consequences. So, Councillor Venner, if you want to share any of the details that you've got, we can take that forward. And then the second is, if we do find we've got displaced people, we pick them up and find places and spaces for them to work. And Louise, you've put something about that in the chat, haven't you, in terms of how the care associations are working together on international recruitment to make sure that there is that kind of space.
Yes, I have. Hi, Louise Bestwick, Chief Exec of Bradford Care Association. So I'll just put my camera on for everybody in a second. So yes, we are fully linked in at the moment in terms of all the West Yorkshire Care Associations with the Yorkshire and Humber hub, in looking to develop a hub and spoke model to support displaced workers within the region. We know that there's probably something in the region of about a couple of thousand who have been displaced within West Yorkshire as it stands at the moment, but not all of those are necessarily coming through, and not all of them necessarily within West Yorkshire. They may be working in other areas of the country, so we are actively trying to do that and trying to get a model up and running as soon as possible, working with the Home Office to support displaced workers as soon as any licence is revoked. But I think more importantly as well, trying to make sure that going forward we're supporting employers who are bringing them in appropriate ways, making sure they've got all the pastoral support and everything else they need and able to meet all the Home Office requirements. But equally, we're also lobbying on a national level around some of the changes that need to be made going forward, so that we don't have this situation occur again, because unfortunately there's a way in which the visa scenario was drafted, in which it allowed non-registered, non-CQC providers to actually bring in international recruits, which has led to sort of some of the significant issues that we've seen. But we are really trying to do our most, and we're obviously working really closely with the local authorities as well on this.
Thank you, Louise. Rachel.
Yes, I just popped into the chat there the update that I actually did earlier in the year about this topic, but there's a couple of things, just the easy things that are on there. One is making sure that staff who are dealing with the recruitment agencies are trained in modern slavery practice and how to spot it, because oftentimes it's the person who's on the end of the agency is the person that you deal with, but you're not seeing their terms and conditions behind that. So oftentimes they will be working the hours that they're asked to, but actually their pay for it is considerably less. So that's one thing. And then the other one is about using the ethical recruiters list, and we know that agency shortages have meant that oftentimes people are desperate and they're using any recruiting list, but actually the ethical recruiting lists are the ones who've gone through and done all that detailed work on the practices. So they're just really practical things that we can do to keep an eye on this.
Thanks. That's some really useful background. Thank you both. Okay, any more questions or comments for Rob or Kathy? Was there anything you wanted to add from your report from the ICB, or any updates from yourself?
Thank you, Tim. colleagues, you have the reports that Rob and I shared with NHS West Yorkshire ICB board. We met on the 26th of June. I think what you'll find actually, which one of my colleagues will put in the chat box later, is the integrated performance system, integrated performance dashboard, which is an overview of the activity across the system. So we'll put that in the chat box now, and we'll do it again when we look at the item on cancer and early diagnosis. So for you as across the system, you can see how NHS services are performing, and we have added, in addition, community services activity. You can also see progress against the overall metrics for us as a system. Our reports during that for that June meeting were very straightforward because we were in a pre-election period. So our next board meeting will be in September, and we'll share more then.
Thank you. Fiona.
Thank you. I forgot to ask this. Does anyone have any intelligence about the new hospitals programme and whether the new government have said anything about that? Because obviously not very much happened under the last government.
I think the manifesto talks about that they're committed to the future of the new hospitals programme. We've got 3 major hospital developments, 2 of which are tied to the programme, and 1 of which predates the programme and is in making good progress. So the Calderdale and Huddersfield Foundation Trust developments, and now that the A&E is open in Huddersfield, and now focusing on the Calderdale developments, the Leeds hospitals developments, and then the redevelopment of Airedale Hospital, given its status and impact of reinforced autoclaved aerated concrete or RAC. So we're taking a very close interest in this, Councillor Venner, and we've got assurances at the moment that we carry on and continue to try and make as much progress as quickly as we can.
Thank you. Cathy?
Thank you, Fiona, for asking about one of my favourite things in talking about capital and investment in NHS infrastructure. What we have opted to do as a system is to work with NHS Property Services to assess the NHS estate. So at our board meeting, in public and in private, we referenced our NHS infrastructure strategy for West Yorkshire, which our colleague Jonathan Webb is leading on. What it's really been helpful to us is give us a full review of the estate, including primary care, and it's helped us prioritise. There are a number of things we already knew. We still need funding, for example, for mental health hospital in Bradford, Linfield Mount, but it also identified a continued system risk for us, including the RAC hospital for Airedale. So what we have is a ready-made list, I suppose, Fiona, that when new opportunities arise, we have that, but we also have opportunities to discuss together across the system how we work together. And as you know, I'm sit on the West Yorkshire Combined Authority Housing, Places and Regeneration Committee, and I think there's a great opportunity to connect our NHS infrastructure strategy with WICA's strategy going forward to see how we can align, particularly how we are investing in neighbourhoods and buildings as well as the infrastructure. So we have information ready to go with the new government when they're ready.
Thank you.
Thanks, Cathy. I'd be interested to see obviously a lot of focus in the government's agenda about getting infrastructure delivered, and I think a lot of the focus on that so far has been on the planning system, but actually there are clearly wider issues than that in the way that we build things in this country and the length of time it takes us to do them, and be interested to see if there are other things that develop around that as well. Rob?
Yeah, and I think just to keep reinforcing the work Cathy's described about the expansion of homes and populations in West Yorkshire, and the need for us to correlate that with the expansion of facilities and staffing in West Yorkshire to meet the needs of those populations. And at the moment, there's a bit of a mismatch. And if you look at the analysis that's been done, one of the things that doesn't get much of a look in our conversations is the primary care estate. And 14% of the health estate is in primary care. So it's a substantial bit. It's you know, it's a seventh of all of the estate is in primary care, and we need a strategic set of solutions to how we deliver good services that are joined up in the community out of modern estate.
Thank you, Rob. Okay, I'm not seeing any more hands. Thank you again for those reports. And yeah, certainly from my point of view, Chair, I'm sure as a partnership would endorse the view that the approach we've got in West Yorkshire of strong partnerships with shared collective and collaborative leadership is the best model to help deliver on the priorities the government's setting out, as well as on the health needs of our community, and we'll continue to make that case strongly. The next two items on our agenda are both looking at two of the 10 big ambitions we set in our forward plan. The first of these is about our ambition to increase and improve the early diagnosis rates for cancer. We have paper that's been circulated, and I'll invite Jason Pollock and Dr. Helena Rolfe to introduce this. So over to you, colleagues. I'm just aware we're slightly ahead of time on the agenda. I don't know anybody can scan the attendance list. Our colleagues with us for this item yet?
Not yet, Chair. Is it worth us doing the patient and public voice item?
We can do, although I think that's sort of directly linked in, didn't? Linked into the following item, but is that something we can bring forward and do now? Kate, yeah.
I know this could mess the agenda up, but I was going to offer that we could do the living wage item, because I'm conscious that Louise and Michelle are already here. So, but that could then move your agenda a little. I don't know.
I think that would be fine, Kate. Actually,
okay?
Yeah. Let's do that. People are okay with that. So Kate, I'll pass over to you.
Thank you. Well, thank you, Councillor Tim. I'm Kate Sims. I'm the Director of People for the West Yorkshire ICB. So I believe this is item 9 on your agenda list. I think it's the last paper of the day, but we'll bring it forward. I would like to pause and just invite, I know Louise has already spoken today, but just invite Louise and Michelle just to introduce themselves, who will be part of this short presentation today, please. Louise, I can see you.
yeah, no problem. So yeah, Louise Beswick, I'm Chief Exec of Bradford Care Association. So we represent independent social care providers within Bradford, but we're also part of the Yorkshire Number Care Association Alliance, which in turn feeds into the Care Association Alliance, which is a national alliance of local care associations.
And thank you, Louise. And to Michelle.
Hi everyone, Michelle Atkinson, Chief Officer at Leeds Care Association, also part of the Yorkshire Number Care Association Alliance and the Care Association Alliance as well. Thank you.
And I believe it's the Care Association's first formal meeting as members, I think, of the partnership. So I'll welcome you as well from that perspective. I can also see Rachel Loftus. I know everybody knows you on this call, I believe, but Rachel's been really instrumental on the working group as well. So I am going to take this paper as read, because I appreciate there's quite a significant detail within it, and I think it's really helpful. There's been already references in today's discussion already. However, if I can just take you through some pertinent points before we open up for a discussion. We as a partnership board, or you as a partnership board, you commissioned through myself and the West Yorkshire People Board a review of the real living wage situation within West Yorkshire, and it was part of our ambitions around the West Yorkshire strategy refresh. So the purpose of this short sort of presentation today, associated with the more detailed paper, is firstly to update you all on where we've got to with that review, because I think there's been quite a lot of comprehensive research. I think to really come back and have a good conversation to further, test the appetite further in relation to the ambition in this regard. And I think essentially, if we remain really committed to addressing matters such as real living wage at West Yorkshire, we need some input, we need some help, particularly around quite comprehensive financial modelling, I think would be fair to say as the next piece. So we have set up a working group, and colleagues who are on the call here today have been really active in that, and I'd like to thank them for all the time you've given me over the many months. As the paper suggests, Councillor Tim, so if this addresses or responds, I think, again to two of the core ambitions of the partnership. The first one is about increasing the number of years that we hope people can live well and in good health. And I think the second one is about addressing those health inequalities, and particularly for gaps for those in households with lower incomes from that perspective. And you all know, as a partnership board, you've previously considered and committed to a number of initiatives with regards to this, most recently back in March with the Fair Work Charter, which colleagues on the call presented, and we've made a real commitment across West Yorkshire. Sections 6 to 11 of the paper sets out the case for change. Why would real living wage be such an important piece? And really, just in summary, it offers a real prospect for, firstly, hopefully starting to meet people's basic needs around, obviously, food and bills and housing, but to give them that satisfaction around a standard of living or a certain standard of living. It helps prevent those ill effects of poverty, which I recognise all of us fully understand in the roles that we play, and it enables our employees both to live but also to work productively and to attend work on a regular basis. I think if we were to summarise our ambition here, we recognise that people who earn below the living wage are already sadly more likely to be facing greater inequalities in the whole of their health and across their lives. And the ambition here is to try and respond to this. The paper sets out in sections 12 to 14, I'm not going to read all of this out, the definitions. There is a difference between the national living wage, which used to be classed as the national minimum wage, and the real living wage. And we can perhaps get into a conversation about that, but the definitions are hopefully there. We did undertake a survey as part of our work, and it would be fair to say, whilst our response rate was primarily from our independent social care sector and our voluntary care and sector, our VCSE sector, it mirrored some of the national data. There was a relatively low response, but it does mirror national data. Again, it's all set out within the paper, but if I were to summarise, the respondents, a third of our respondents were saying that they would not be able to provide currently a real living wage, whilst it was their ambition, to all or part of their workforce. In some cases, that was all. That roles that weren't receiving that real living wage standard primarily fell within care and support working staff, domestics, drivers, administrative staff, maintenance staff, and in some cases moved into some of our more senior care workers within some of the sectors. And over half of our respondents said that where they had been able to provide real living wage, that they had supplemented the statutory income that they received with other funding streams, and some of those are detailed within the paper. So there were some real concerns cited in the responses, which are detailed in Appendix 1, provides some further detail there around both being able to maintain the real living wage, but also if they could maintain the real living wage, or we were able to introduce it, then the pay differentials for the roles that are higher. I haven't got the time in this session to take you through every detail, but I think what I would encourage colleagues to look at is that section 22 to 46 then really takes you into the detail across social care, VCSE, local government, our hospice sector, and a reference also to the NHS and our NHS organisations. If I was to pick out just a small number of aspects in social care, that there is reference within that actually to international recruitment, which Councillor Venner has just referenced. So I'll move on from that, but it absolutely echoes the points that have already been discussed today. But also the impact of fee rates for residential care services sector and some of the challenges in being able to actually respond to some of this. Again, within our voluntary sector, our third sector, real challenges in terms of both meeting rising costs of living and on costs, which are outstripping the uplifts that colleagues within the VCSE are receiving. And within our hospice sector, a real commitment to the living wage, but are currently, unable to actually guarantee that because of, again, associated with fees. And there's a lot of detail, which obviously echoes some of the national findings in this regard. I think in summary, the paper highlights, as we perhaps suspected when we were asked to undertake this work, that we have a real gap between, I believe, the ambition of the partnership and our financial reality. And we recognise, and one of the reasons for us wanting to come back with the paper, Chair, was we recognise the current financial situation and really wanting to make sure that, that the appetite was there for us to continue with this work. It's been really difficult to provide any information about the estimated cost of closing the gap. And I know, questions that I've already been asked in relation to that. And one of our requests is if the appetite remains there, that we do secure some resource from across the partnership to use finance colleagues to support some of the significant financial modelling from that point of view. My colleagues on our working group, it would be absolutely fair to say we believe the real living wage is one part of a much wider ambition around health inequalities and healthy employment. And we recognise that as part of impacting on people's economic security, there are other aspects, of course, including guaranteeing some level of minimum hours for colleagues, providing as much advance notice of shifts for people who are on flexible working, accessing to health and wellbeing services. And we worked really hard to keep our ambition focused on this agenda because I think we recognise there are many, many other aspects to this. So hopefully the paper has provided an update on the work that we've done and the findings both nationally, locally and regionally around this. We'd like to open up in a minute to discuss the continued appetite for this, the real living wage agenda, and if so, the sort of ambition around the timeline for that within West Yorkshire, and as I've mentioned, the financial modelling. If I may just invite Louise and Michelle to see if there's anything you feel you wanted to cover that I've not, before we pass back to the chair. Thank you.
Thanks, Kate. I mean, just want to say, obviously, welcome this opportunity to sort of work on this paper and present this paper. And it does feel like quite timely, given sort of the direction of travel we are seeing with the new government. So it just feel that, this possibility to get ahead of the game and fully understand what the implications of a fair pay agreement be and potentially any changes around integration in a national care service. I think it's just important to note, obviously, Kate mentioned a few things. It's not just about the real living wage, and obviously it is arguable whether the real living wage is even sufficient actually for that base rate if we look at for care, given that many supermarkets pay in excess of that. But it's also important to recognise the differentials as well, where we're looking at senior care workers, managers, etc. And we need to continue to develop those skill levels and those skill sets and the leadership within our system. And although, yes, this is really difficult to necessarily quantify, and I think many of the same challenges that we experience in the independent care sector are experienced by our VCSE colleagues, but there are things that potentially are within our gift in terms of the things of maybe how we commission, the way we commission. I know that's certainly a massive factor for the independent sector and the VCSE, and the way in which work is commissioned. So there are different, we can look at the wellbeing, occupational health, access to that. So there are lots of things that we could do that maybe we could actually start to begin on while waiting for that sort of national picture to start to materialise. And there are examples up and down the country of where this does work, and where local authorities have put in place a sort of a fair pay agreement and increased the fees accordingly to do that. And it has seen welcome benefits. And the closest in Barnsley, we see that where they pay £1 above the national living wage, and that majority of providers do take that. So it's really something that we should focus on and be an ambition of the partnership.
Thank you, Louise. Michelle?
I would just say I echo everything that's been said, and I think one of the things I would also add is that given the financial pressure across the ICBs and the local authorities. It is an ambition of many independent sector providers to pay real living wage, but it's just not affordable within the fees that they are being paid by the local authorities. And we know that that's it's a central government issue because of the funding that they allocate to the local authorities. But yeah, the providers would love to pay real living wage. The only way that they could do that, if it's not within the fee from the local authority, is to increase fees to self-funders, but then self-funders are cross-subsidising local authority individuals even more, and the cross-subsidisation is already an issue, so it's not really feasible for providers to do that. So yeah, they would love to do it, it's just not affordable. But given the financial issues across all the wider system, I think we do need to work in partnership. As Louise said, maybe identify other areas where we can perhaps identify some quick wins and continue to aspire to introduce this at some point, as you said, Kate, but gauge the feeling today to see if it is something that we want to continue pressing with. Thank you.
Well, thank you both, and we'd be happy to sort of pick up a general conversation now, Chair. Rachel, I know you've been instrumental in this paper as well, so if there's anything you wanted to add as well, but really happy to have a conversation to, I guess, test the current position with colleagues before we agree a way forward. So thank you.
Thanks very much, Kate. Thank you, Louise and Michelle, for your contributions, and thank you to everyone who's involved in the working group. It's a really important piece of work. Illuminates a lot of the issues about making progress in this area, which I'm sure is something that we all want to do. I think it's interesting that, you know, you've highlighted the point as well that it's not just about wage, there are other issues, and I don't know, maybe Katie perhaps can pick up in the conversation, but how far some of those things are picked up in the Mayor's work around Fair Work Charter as well. I think that comes through in lots of settings, that actually it's not just the rate of pay, it's the way people are expected to organise their lives around work that are challenging as well. I'm sure it is something we want to make progress on, but equally we need to be realistic and recognise the huge challenges there are in getting there. I think it will be interesting to see how much the legislation around employment rights and so on might influence this as well. So I've got a number of people wanting to contribute. I'll start off with Majid.
Thank you, and thank you, Kate and colleagues, for the presentation. Yeah, so in terms of, I get it that the living wage isn't the only sort of issue. There's a number of other factors that we consider, but I think some of these people on the sort of lowest end of earning are where some of the greatest health inequalities and other inequalities exist. And yes, we have got financial pressures, but we've got financial pressures across a number of areas. So I don't think we should dampen our enthusiasm or our commitment. I think we should try and find the resources. And there's a danger that sort of these areas end up in the too difficult to do box. But I think we have to recognise that these communities, these individuals, these families, some often have more than one job just to survive, and that does have an adverse impact on health. Some of these people live in poor housing conditions, etc. So there is a consequence later on, and we all know all about these things. So I would say we've got financial pressures everywhere, and you know what I mean. We shouldn't sort of, this might be an easy play to say, okay, well, we won't do anything here. So I would support us maintaining our sort of commitment and enthusiasm and spirit towards this living wage.
Thank you. Fatima?
Thank you, Chair. Hello, everyone. My name's Fatima Khan Shah. I am the West Yorkshire Inclusivity Champion, which is a role shared with the Mayor of West Yorkshire, Tracy Brabin. and the Integrated Care Board focused on equity and social justice. So Councillor Swift, you kind of mentioned my first point, which is there's a great opportunity to take some learning from the Fair Work Charter and Tracy Braven's aspiration to support people with, terms and conditions as well as the real living wage. So I'm happy to pick that up outside with colleagues. The other bit that I wanted to allude to, and Majid started to reflect on this, was the sort of connection between health and wealth. But I wanted to also talk about money in a different sense, which is that if we get this right, it really supports our aspirations on things like admissions avoidance and effective discharge. Because if we've got a supportive infrastructure that enables people to stay at home, to look after themselves or be supported by their loved ones, the impact on our health and care system will significantly diminish. And I think we can't emphasise that enough. The other thing I would emphasise is the importance of recognising the service carer lived experience perspective. I know firsthand how hard it is to get effective care workers coming into your home. I also know what it feels like that once you've created that effective relationship with that person, what it feels like when they move on, because they can't afford to stay or they've had to go and get a better paid job. That has a massive impact, not only on the experience of people using those services, but the likelihood of them requiring a health and care intervention, which is really costly. So I think in the modelling, we really need to encourage and factor in those elements. The final thing I will say is, and Majid again alluded to this, is the sort of disproportionate socioeconomic factor this has on certain communities. And what I say about that are the gender mix, because this is proportionately quite often women working in these sort of roles, but also ethnically diverse individuals who come from really low socioeconomic prospects and also low educational attainments. So I suppose what I'm thinking is this is part of a wider conversation that we started in the previous session of the relationship between our system and our work with the wider combined authority and the determinants of health. And it's a really great opportunity for us to showcase our aspiration of not dealing with the manifestation of a problem, but what is causing it in the first place.
Thank you, Fatima. Brian.
Hi, I'm Brian McGregor. I'm a GP, but I'm also chair of West Yorkshire LMC Exec and chair of Regional Council for Yorkshire for the BMA. Fatima's quite rightly stolen some of the points I was going to make about the overt discrimination that you see in this, particularly gender pay gap issues in relation to this sort of work. But I was just going to ask, have you actually looked at the impact of this within general practice as well? Because in the last year, this has been a significant financial pressure within general practice. There was a 1.9% uplift to all their funding, and yet we have pushed very hard for them to meet the living wage payments. So that's been a 10% increase for those staff. But then you get other staff that want to actually try and maintain their pay differentials. And in general practice, we've seen a significant turnover, particularly of reception staff, who have a very difficult and confrontational role. And they're often those that are on the living wage. And we're seeing them being offered better conditions and better pay elsewhere. And they're actually a very highly skilled workforce that we're having to try and replace and retain on an ongoing basis, on a regular basis. And we need to look at how we, as a system, support these individuals, particularly at the lower end of the wage scale, but also the services that are being provided and the providers that actually arrange these services to try and actually improve and make sure they can invest in these individuals, because it's an investment in our workforce. And fundamentally, it's the right thing to do. And I think that's actually what we all need to be our starting point, is we shouldn't actually be challenging this at all. It's actually how do we facilitate it rather than challenge it.
Thank you, Brian. Selina.
Hello everyone, I'm Selina Douglas, I'm Chief Exec at Leeds Community Healthcare Trust, and this is my first meeting, so thank you everybody. I suppose I'd absolutely agree with what colleagues have said already, and if it was a big Venn diagram, actually improving people's life chances is about giving them good and steady employment and paying and supporting them to improve that employment throughout their life courses. So I suppose to me, I don't want to make the points that other colleagues have made, but it's an area if we disinvest, actually is going to have a huge impact on us and on the wider societal issues. And as anchor institutions, I think there's something about how do we make some commitment to making sure this forms part of all of our strategies going forward. And I look at things like it's really easy when you've got financial restraint to think about stopping things like hyperlocal recruitment, supporting some of our global majority individuals and our international nurses, all the support around those as well. But actually, it's a false economy for us because we'll just end up with not having the workforce going forward and not having the trained and experienced workforce going forward. So I think for us to think about how do we support this, but how do we maintain as well some of the great stuff that's happened locally and in West Yorkshire to support individuals to maximise their outcomes. And importantly, it's not just about the generation now. It's about children and young people going forward and giving them the ambition and the skills and the good jobs in the health and social care sector that in 5-10 years' time we are going to absolutely need as a system when we look at the retirement age of some of our qualified workforce at the moment. So for me, let's not be short-termist about something that we've got to think about the long term and also think about, like I say, those multifactorial issues that are happening within those communities.
Thank you. Len.
Yeah, thank you. My name's Len Richards. I'm the Chief Executive of Mid Yorkshire. And I'm very sympathetic to the point that Selena's made, Brian and Majid, really. I guess I just wanted to draw attention to something that's in the sidebar that Kim Shuttler put in there. And I guess just highlights that we sometimes play into this in quite a negative way, by only offering short-term contracts to BCSE, not offering uplifts that actually reflect the minimum wage or keep pace with inflation. And I think if we were to start anywhere, there is something that we can do with BCSE about making a much more stable environment for them, contracts over a number of years, and as a minimum, provide increases that are in line with inflation and increases that enable them to move to the minimum wage. So I think not only, we talk, I guess this is the gap that was being talked about earlier on. We talk very supportively of this, yet our actions in some sectors don't support the minimum wage. So I would ask us really to play that through and with the BCSE sector particularly.
Thank you. Rachel.
Yeah, I'm Rachel Loftus. I work for local government across West Yorkshire, and I was also part of the working group, as Kim said. What I was just going to point out is that when we had the opportunity, when we had the funding and we had the opportunity to do this in the winter of 2021, which I've described as the most challenging winter, we in amongst all the challenging winters we've recently had, that probably was the hardest one. The feedback from what that was, it did reduce turnover. It did increase retention, and the feedback that we got from those workers were that little bit of help made them stay working in a sector they want to work in. We talk about the comparison, with, Aldi's paying £12 now, all those other things. Actually, people want to work in care. People want to have meaningful careers and they want to work for us, and they want their work to matter. And that's same across, our third sector colleagues have said that, drivers and other people who aren't there. So there's something in that around what is it worth to us in terms of that retention. And actually advocating for that to be a national policy, because actually if we're just losing staff all the time, all we're doing is spending more training new staff and recruiting new staff. So there's something in that around kind of changing that vicious circle of losing staff we absolutely need in these roles, and then actually welcoming people into our health and care workforce with the opportunity then to progress to better paid roles as time goes on. The reality is, unless local authorities have the funding to be able to do this, they, even as smartly as we possibly can commission, it's not possible to make good on this at this point, and it's a waste. And I think this is something that we do need to bring to national attention, based on, we're all in agreement this is something we would like to do, but at the moment there's no adequate way of doing it. And it was only when we had that additional funding from Winter Precious money that we were able to put our money where our mouth was in West Yorkshire and did that, and it did work. So there's something in us having a track record of when we were able to do it, we could, and asking for that same permission again.
Thank you, Rachel. If I can, so just a couple of cards to bring Kate back in. I mean, the nature of it clearly shows that there's a consensus that we want. It is something we absolutely should commit to as an ambition. I think putting an appropriate timescale on that, whether the lifetime of this Parliament is a reasonable length of time, one would like to say 12 months, but clearly is not deliverable in 12 months. It feels to me perhaps the next step is identifying one of the next steps is identifying specific actions that we can take within available resources that will help to make it more popular. I think the thing about length of commissioning and support for voluntary sector is one. You know, I fully endorse a lot of the arguments that have been made here. I think, you know, the economic impact, low paid people, we're always talking about people who spend money in the local economy, so it's beneficial to the whole economy. I'm sure the impacts in terms of turnover and quality are really significant, if hard to put a figure on. You just have this feeling instinctively that actually it's something that overall, if you can pull together all the system and wider social costs, actually paying people a real living wage probably is cost neutral and maybe even more than that. But of course, it's actually releasing the resource in the right place to do it. So I'm suggesting that there is a clear commitment that we want to do the work on identifying the next further practical steps. And I noticed, Kate, coming back, you said particularly about sort of assigning resources, which you can't directly do from here, but just perhaps some help from you. What else you want from us to enable this to happen?
Well, no, firstly, thank you. I mean, very briefly, thank you. I know it's a conversation we could have all afternoon, but really grateful for everybody's strong endorsement. Whilst that was hopefully what we anticipated, it's always important to test it, given, you know, the current climate. Just very briefly, and I think it goes to Brian's point, I think if we have this commitment, then the next thing is we don't feel fully clear and confident that we've got the full size of the challenge and the agenda. And Brian, you raised about general practice, and whilst I'm working with colleagues in primary care, it goes to a question, Chair, that you raised with me today about, whilst I reference the NHS, there's other people who support the NHS contracted organisations who again that this would impact on. My perhaps proposal is twofold. One, I digest everything we've heard today, and I think there's almost an action plan coming from this. One specifically about the real living wage, and one that perhaps goes to some of the other points that Len and colleagues have made. The plea in regard to resource was more the fact, not that people to name colleagues today, but if we are committed to this, I need input from people's financial professionals to say, how do we start to really size up the cost modelling of this? Whilst we've got some commitment across some of the sectors, it's really hard to size this up in its entirety without financial colleagues involved. So that's the request, which, if I've got your endorsement, I can write out to your organisations to say, how do we make that happen? Because I think it's a key question, is if we've got the ambition, what would it cost us? So thank you, if that's helpful.
Thank you, Kate. Yes, and I think we're happy to give that endorsement. Susan?
Yeah, I think we've all done the work. So we all know at some point we'd all love to do this. Going back to Michelle's point about the third sector and how we actually commission third sector providers on care, we should all be paying them more money, but we haven't got it. So I think when we worked it out, I'm sure we've all worked it out as local authorities. We worked it out a couple of years ago, and I can't remember the top of my head actually, but I think it's probably something like £5 or £8 million additional cost a year more. And I'm sure we all have those numbers, so it shouldn't be too difficult to put those together. Of course, it's in the context as we're now taking £120 million a year out of the budget. So that's just what we're grappling with in local authorities at the moment. But we've all got those numbers, so it should be really quite easy to pull them together, I would have thought.
Thank you. Okay, thank you very much, everyone, for that item. That was a good and valuable discussion, and and perhaps one of the things that might come out of it is a little bullet point briefing that we want to share with our members of Parliament as well as we go along about the issues too. Okay, I'm going to take us back then to item 6, and thank you, Jason and Helena, for waiting patiently for this, and I'll hand over to you to introduce this, if I may.
Thank you. So just introduce ourselves firstly. So I'm Jason Porlock, and I'm the ICB Associate Director for Cancer and the Managing Director of the West Yorkshire. And Helena.
Hi, I'm Helena Rolfe. I'm the Clinical Director for the Cancer Alliance.
And what we do is obviously we shared a paper with the board in advance. We just have a few slides which I'd like to share to kind of start off the discussion and give a bit of context to the message in the paper, if that's okay. So I'm going to share my be great if somebody could confirm. Okay. Just checking, colleagues can see our screen. Should we see the first slide, the agenda item 6?
Yeah, we can see it.
Fantastic, thank you.
Great. So one of the West Yorkshire ICB ambitions was by 2024, 1,000 more people will have access to potentially curative treatment for cancer. And as you can see by the graph, this started 2018 as a baseline. And by the end of 2020, the cumulative additional volume of patients diagnosed at early stage, which is stage 1 and stage 2, was 2,411. So this was obviously exceeding the target by 1,411 despite the pandemic. So I think that was obviously a really good target. There's more to do, but it does show that in West Yorkshire we really have galvanised, the system to really try and kind of smash this target. So going on from that, this graph shows the England, which is the proportion of cancers diagnosed at an early stage, which again is at stage 1 and stage 2, and the purple North Eastern Yorkshire regional progress, and then the green line is West Yorkshire ICB. As you can see, back in 2019, we were significantly below both of the other two, but with a lot of hard work over the last couple of years in particular, we've improved exponentially, and we're now tracking the North Eastern Yorkshire regional progress and exponentially improving. So I think this has been a massive achievement with all of the kind of system working that we've been able to deliver, and we're committed to continuing to close the gap. One of the key kind of drivers in improving cancer kind of outcomes for patients will be to continue to drive down smoking prevalence. As you can see, this graph shows since 2011, smoking prevalence has decreased markedly. In West Yorkshire, in 2022, smoking prevalence was at 22%, which was just below the England average. We've been able to kind of demarcate where each within the ICB statistics lie, and there's still much more work to do, but we're working together across the system to roll out the lung health checks, which part of that is encouraging people to stop smoking, but also giving them a lung health check to assess their risk of cancer. Just hand over to Jason.
Thank you. Key points, just to build on, is that actually there has been some really good progress made in West Yorkshire, with all partners working together in terms of helping to deliver our ambitions to improve the stage of diagnosis, and indeed actually make a difference to one of our key population health challenges of the system. Because it's a sad but sobering fact that unfortunately 1 in 2 people in West Yorkshire will be expected to be diagnosed with cancer at some stage in their lifetime. And whilst it's a really positive thing to say that more than half of those will live for more than 10 years following that diagnosis, that means there's a real significant pressure on how do we deliver services which are responsive, which are personalised around the needs of the individual, which are tailored, and we actually have an approach which goes right from the prevention of illness right through to effective treatment, right through the care pathway, through to health and end-of-life care where required and needed. And this is some of the work the Cancer Alliance does. I would reference that this is something we do together right with our partners right across the partnership. And we try and deliver some work which actually helps to mobilise some of the ambitions we've talked about. So we have a purpose to bring local partners together to transform outcomes. We have ambitions to transform services that cancer care treatment support are wrapped around the patient right through the care pathway. We have 5 strategic objectives of Cancer Alliance, which are to improve patient and care experience, to harness networks to deliver better outcome for people, to reduce inequalities in access, care and outcomes, to adopt innovation, new models of care, and to develop our people and to actually have a focus on the cancer workforce. This year, building on what's described in the Joint Forward Plan, what's described in the delivery plan for the Integrated Care Board, and working again with alongside of our primary care partners, our acute partners, the Wyatt and other functions, work on the operational performance as to make the functions around improving the fast diagnosis and the 62-day standard within West Yorkshire. It's not directly referenced in the paper, but just to say and share with the board that, again, we're making good progress on the faster diagnosis standard across West Yorkshire. And the most recent data, 80% of patients were either confirmed with cancer excluded from the pathway within 28 days of referral, with a rate to 86%. On the 62-day pathway, we track and exceed both the regional and the national average for performance. We're below than the NHS Constitution framework metric at the moment, but our most recent performance, which was recorded 73.4%, and that looks at how quickly we diagnose, how quickly we treat cancer once the patient presents. So we've been looking at the operational performance asks. We've prioritised a review of the bladder and pancreatic pathways locally to look at some of the gaps in terms of how patients be referred, how they're being managed, and those impacts on the way we're delivering activity. That builds on the national priorities around breast, urological, lung and colorectal cancers. And we're also expanding our work in terms of encouraging people to come forward with screening, and in particular look at the national screening programmes, which are breast, cervical and colorectal cancers, but also looking at the lung health checks programmes referenced by Helena, and the work around kidney and liver, and what we can do around multi-cancer blood tests as a diagnostic tool in time. And we're also doing a lot of work as a system, including with voluntary community and social enterprise partners and with patient groups to consolidate and create an innovation pipeline. So do a lot of work in terms of improving quality for cancer patients, doing work in terms of workforce redesign, transformation, and improvements around services delivered for non-surgical oncology, which is around chemotherapy and radiotherapy. What we can do around rarer cancer and the role of artificial intelligence in the way in which they will kind of help the way we deliver improved cancer care. And we also want to make sure that we work both in partnership with all the places, and the Cancer Alliance context that includes Harrogate, but actually how do we make sure that investment's in place both through the work we fund in primary care, the work that we deliver in terms of place-based clinical and service improvement leads, and also what else we do to actually make sure again that that we kind of have a span of focus which is right across the spectrum. Just want to give a couple of examples before we open up for questions, just in terms of some piece of work again that we've done with our partners, which we're really proud of. So this is called the Cancer Smart campaign, and it's a collaboration between the Cancer Alliance and the Yorkshire Cancer Community. The Yorkshire Cancer Community is a patient-led charity, and it's a voluntary community sector organisation who run our patient involvement work. They've done some fantastic work to actually get people talking about the symptoms of cancer, encouraging people to come forward and actually breaking down some of the stigma and the barriers around talking about cancer openly. So they've got 201 digital champions across West Yorkshire, more than an increase of 40 in the last year. And they delivered 15 different information stalls, podcasts and webinars. Again, some have got national prominence. We've been to a number of support groups, taking part in a great number of face-to-face, spoken to more than 2,000 people, expanded their social media reach through both from Facebook and Instagram, as you know, so really significantly. And again, what this is about is actually building up a conversation about cancer led by people who've been affected by cancer themselves. And we found that's a really effective approach. It helps us reach sections of our community which otherwise wouldn't necessarily respond to kind of us in the traditional ways of working. And our second one is just to talk about some great work that's been done in terms of improving access to cancer screening and tackling health inequalities. So last year we ran a campaign around reducing barriers for cervical screening amongst the transgender population. And we worked with a charity called Outpatients. And what we managed to deliver there was really fantastic. We managed to deliver 40,000 impressions across social media. We managed to deliver a whole system campaign of posters and leaflets at train stations, bus stops and billboards, close to 5 million different And crucially, we actually have managed to track the impacts of this campaign within some of the areas of West Yorkshire, in particular in kind of Hebden Bridge and other areas where we've seen real differences in people coming forward for screening and in actually changing behaviours arising from actually having a campaign which has been designed by people from that community working together with us on a partnership approach. So that's kind of the message and the spirit around what the CAN's.
Is anyone else having audio issues?
Yes, we suddenly
Yes.
lost you, I'm afraid.
Yes.
Sorry, I'll just repeat what I was saying that last slide. I'm sorry if I repeat myself. Just to say that we're really keen to collaborate, working together. We're really keen to co-produce. We're really keen to actually continue to work on reduced health inequalities and improving access to screening. And we think we can really make a difference. And that's kind of the spirit of what the Cancer Alliance does, but also with it right across this parts across West Yorkshire. It is everyone coming together, and we think it's making some of the work we do and some of the outcomes we're achieving, but recognise that we've got a long way to go to deliver international comparisons in terms of what we can achieve for people affected by cancer. So we'll stop there. Our request of kind of the partnership board today was to kind of give us any additional insights, perspective around, what else you'd like us to think about doing and where you'd else like to focus, but really delighted to take questions. Thank you.
Thank you very much. So, colleagues, questions or comments, please? Yes, Majid.
Yeah, thank you. Thank you for the presentation, and it's good to see that some of the trajectories are going in the right direction and stuff. And you spoke about some of the sort of focused work to tackle inequalities and how effective it was to sort of engage people to access screening, etc. One of the questions I've got is, how do we sustain that and how do we embed that approach in terms of outreach, so that it's not a one-off exercise? We get people in and then 6 months later they forgot us and we forgot them until the next campaign. So linked to that question is, what are we measuring and what are we monitoring? So when we say we've got diagnostic improvements, is that diagnostic improvements for everybody? Are we measuring demographics, or are we just looking at the headline number? Because what we want to make sure is that it's improved, things are improving for everyone, and some sections of the community are not left behind. Thank you.
Thank you. So I'll pick that question with that's okay. So absolutely. I'll give you a good example from the Targeted Lung Health Check programme. That's a programme which is deliberately focused on areas of high smoking prevalence and also areas of high socioeconomic inequality. And what so far is we've looked at the early stage of cancer diagnosis rates for lung cancer. And we've now got a scenario whereby you're more likely to have an early diagnosis for lung cancer if you come from the lowest socioeconomic deciles in West Yorkshire than the most affluent socioeconomic deciles. And that's because of the direct impact of that campaign. And that's essentially turning health inequality on its head. It's something we're really quite proud of and want to do more of that work. In terms of, you made a really good point around actually what do we do to make sure it's a one-off, and that's around kind of build that community advocacy programme we talked about through Cancer Smart and some of the work with VCC organisations, and also some of the investments in primary care, cancer care coordinators, also the work around champion roles. And we really want to build a culture which sustains itself. So what we tend to do as a Cancer Alliance is we work with partners to kind of get things off the ground. We look at sustainability, we look at measurements, and then we kind of create conditions for things to thrive after we take away a direct role and influence, and that's something we want to continue to do. What we do look at as well is we do look at specifically all the cancer waiting times measures by demographic factors. And so we can look at, for example, the rate of referrals by demographic factor, the rate of early diagnosis, cancer performance. And what we also do is we work with all the acute provider trusts and to make sure that influences the way they plan and deliver service and how we make them more accessible. We also have a patient experience strategy improvement to help us understand ultimately how we design services and deliver them in a way which is personalised to the needs of kind of the diverse range of individuals which we're serving West Yorkshire. So again, a lot of work in that area, Mash.
Thank you. Susan?
Yeah, along a similar vein, really. Just a couple of things on the inequality stuff. First of all, are you differentially communicating with people? So we don't just send everybody a letter and say you need to make an appointment between 9 and 5 Monday to Friday with an hour for lunch, and then they don't get in touch, you know, because people work 9 to 5. So things like that do my head in, actually, because I do think that's a really unequal way of engaging people in the health system. So are we addressing that? And my second question is, obviously we learned a lot through the pandemic how we make sure that the most disadvantaged people in society access the right support, and we put a lot of emphasis and resource into those communities where it was harder for them to access vaccines, for example. So have we learned from that, and are you applying some of the rules, some of the lessons learned into this environment now? Has it changed how you operate, and if so, how?
Yeah, so I think I'll just give a example of the work we do. We have an innovation actually using some of our screening programs called Apt Health. And what this is basically, it's essentially a text message system which can work on a smartphone or a dumb phone, and it allows someone to directly book their appointments at a time of their preference and choosing. But it also as well takes out one of those barriers which people can experience, which is trying to get through on the telephone. Now, what we do as well, we also have personalised text messages which are written in a language of choice and using behavioural science techniques to actually work out if we're trying to influence this particular individual and we're trying to influence into a positive behaviour, for example, coming forward for a cancer screening programme, what do we know around what message works? And we've actually got a diverse range of opportunities to do that. And again, that's something we've learned from the pandemic, and in particular vaccine campaign, which is, as you say, one size doesn't fit all. And we need to think about that in terms of what we do. We are also supporting some research in that particular topic with Imperial College London and the University of Bradford, looking at essentially how you use behavioural science techniques effectively and how we actually work with and understand the barriers for screening, for example, among some of disadvantaged groups and underrepresented groups of society. So one particular group being South Asian female community in the context of cervical screening. So again, we're doing that work to understand what works and also both influencing that directly in the way that we commission and deliver some of the improvements we do, but also what we encourage amongst the providers we work with in terms of what they're doing too.
Thank you. And Fatima.
Sorry, I couldn't come off mute then. I suspect someone was sabotaging because they're sick of the sound of my voice. So firstly, I wanted to completely echo what Councillor Hinchcliffe just said, because they were part of the questions that I was going to ask. But firstly, Jason, I want to just share an experience I had where I went to a screening that you facilitated of stories of people, their lived experience of cancer, and how you've delivered some really positive outcomes for them and their loved ones. And I would encourage anybody in the board to watch those videos because they're really, really powerful. My questions were sort of a really practical one. So you mentioned already some of the challenges of people from ethnically diverse backgrounds accessing things like, cancer screening or the prevention, but also the fact that actually having a cancer diagnosis for someone of my heritage is a really taboo subject. So they don't even tell people they've got cancer. They don't even tell people that they're receiving treatment, and they hide it. So, like, for example, quite an obvious way that I've discovered that somebody's living with cancer or receiving radiotherapy is when they suddenly start wearing a headscarf because they've lost their hair and they've chosen to wear that rather than to tell people. So I wonder whether there's a role for myself as the inclusivity champion, but also working with other VCSE organisations and community influencers to facilitate some really powerful conversations about this particular issue. The second one was whether we could work proactively with faith leaders. So we're doing a lot of work at the Combined Authority with the role of faith and health. And there may be an opportunity for us to do some innovative work in that space and use the power of faith leaders on this agenda and really addressing some of those taboos. And then the final one is just a really practical one on the sort of cost of living crisis and a really practical challenge that some people have of just physically accessing healthcare. So, I mean, I'm going to plug it again. Jen's done it once. We have got the bus consultation out there. Do have your say about the buses. But also, is there a further opportunity for us with this new opportunity of transport to really work collaboratively and innovatively to make sure that people that are accessing treatment outside of their local borough because they need specialist support can physically get there? So I suppose what I'm saying is there's some really great stuff, but we can take it to the next level if you're up for it.
So summary question, both Helena and I, indeed the rest of the cancer are absolutely up for it, and indeed wholly supportive of everything you said there, Fatima. The key points for us is that, again, there is quite a lot of insight evidence which suggests that, some services for cancer are highly specialised, so they can only be provided in Leeds and that's right for clinical quality and other factors. But that does mean that some people do have long journeys, and those journeys can be long for people, particularly don't have access to their own car, don't have their own supported transport, and indeed the time commitment there, both for them, their families and carers, can be significant. So again, we're absolute support of anything we can do to reduce and break down those cost of living challenges for people, break down the barriers of access to transport. It's a really key part of our consideration around the non-surgical oncology model. We're very supportive of what's done through some of our partners in Macmillan, for example, in terms of offering grants to people going through cancer treatments, as well, to recognise that, sometimes for a person, a cancer diagnosis can be life-changing in terms of it turns around that person's ability to work, the ability to care at home. It can be a life-changing consequence. Again, really thinking about that's very important. And absolutely, there is a lot more to do on breaking down the taboo around cancer. It's not sorted. And we've made some really good steps and progress with a lot more work to do. And again, we welcome all that kind of opportunity to work with the faith leader community, indeed yourself and your team, and really keen to work together. Thank you.
Thank you. Fiona.
Thank you. Your paper referred, and Fatima's just referred to this as well, to needing to access specific population groups. You mentioned South Asian women, you also mentioned the Gypsy and Trafford community, in terms of groups of people that don't have such great outcomes for cancer in terms of getting diagnosed later and then having a poor prognosis. But sorry if I missed this, but I wondered if you were doing anything specific about deprivation, because I know there's intersectionality around deprivation. So in tackling, say, the Gypsy and Trafford community, you are also going into a deprived community. But we know that there are much higher rates of living for more than 10 years after diagnosis for people in more affluent communities compared to more deprived communities. So I wondered if you were doing any specific targeted work that was around deprivation.
Yes, so from both elements, to be honest. So from the perspective of, you're right to say that people from more affluent backgrounds, due to health inequalities factors, are more likely overall to have, a better outcome from cancer treatment, so you have a longer life following a cancer diagnosis. For that particular reason, we have a Living with Beyond Cancer programme, which recognises that for people, the experience of cancer doesn't start when they begin the treatment and end when it completes. It's quite often a significant multi-year event for somebody. For some people, it's often managed a chronic condition. And what we try and do, therefore, is look at the needs of the individual and put them in the heart of it. So we do what's called a holistic needs assessment. It's a programme done for our Living Beyond Cancer programme. And that's looking at not just the cancer treatment, but the range of impacts as that individual, which can be quite diverse and different. So that's everything from financial need, social need, spiritual need, psychological and or social need. And we make sure those needs are kind of addressed at the point of diagnosis and regularly, both at the end of treatment and in follow-up thereafter. That same particular programme is available for people from low socioeconomic backgrounds too. So it's not differentiated specifically by socioeconomic background. However, we also would say is that those people have more complex needs, and that package of support is in place when actually people need that service when they actually go through that. What we're also trying to do as well to make sure there's investment in roles in primary care as well to support that, to make sure, for example, that each person has a key point of contact in primary care. Particularly when they're going through a cancer journey experience and aftercare as well, that they can actually get through to actually have an appointment for a needs assessment where it's required. Again, that's a big part. It's not specifically referred to in the paper. That's a big part of what we call the Living Beyond Cancer programme. It's a key part of what Macmillan Cancer Support we work with closely. Again, I'm really quite keen to champion some really good work on that, in particular in Calderdale and in Harrogate. And we're trying to learn and spread that right across the system.
Thank you. Jen.
Thanks very much. 2 points, if I may. Firstly, just from the perspective linking this to the combined authority agenda, obviously we've already mentioned transport and its impact on air quality, so that's preventative measure. But I think in terms of thinking about the opportunity to link with more of the sort of treatment end, but also maybe innovation in screening techniques, just making sure you've got that connection through to the health tech strategy, through to health innovation networks and so on. I'm sure that's covered off, but just wanted to, you were asking to check what the right connections have been made. So that's just one point. And then secondly, it links to a number of the points that have already been made about different cohorts who would need additional support to access screening and so on. Linking this to the next item. Now, I did my public health dissertation on barriers to access for screening for people with learning disabilities a long time ago, but sort of memory from that was that broadly fell into groups around scarcity of information, fear of medical intervention and embarrassment. Now it feels like we could take action on sort of all of those areas, but particularly seems straightforward to provide better information, better quality of information. So I just wondered if there was anything further we could be doing on that, particularly as next item on the agenda, so relevant to this. Thank you.
Yeah, it's absolutely. So just on the point about the health innovation networks and some of our links into kind of health tech and other industry. They're represented on our board, and indeed we have really close working relationships with Amy, Helen and her team, and again they're really supportive in terms of the work we do, for example, on the small business research and innovation and initiatives, should say, and that's been the example I gave earlier about the APT Health came from that route. On the topic of learning disabilities, I absolutely agree with what you're saying in terms of the multifaceted range of barriers which people can experience and how they experience those barriers. We have taken some actions as a line set to make a difference. In particular, we have developed discrete information resources around the use of the fecal immunochemical test or FIT test in people affected by potential lower gastrointestinal cancer, something which has been developed in West Yorkshire, shared nationally. And we've also done some significant work in terms of making sure that people with a learning disability, potential cancer need, are essentially being flagged and mapped in primary care. And one point which we've very recently picked up, and again we're doing some further work on, is through local LADA review, is the opportunity to make sure that where a learning disability creates a need on a cancer referral, that can be flagged at the point of referral, and that's actually in which we deliver the activity in primary care settings. So there's more work to do on that particular point, Jennifer, but again, really helpful. And again, it just reflects what we've been trying to do.
Thank you. And finally, Kim.
Thank you, Councillor Swift. I just want to link to some of the comments that my colleagues have made around health inequalities and something Susan mentioned in terms of learning from COVID. Oh, sorry, I should have said I'm the VCSE lead and the Senior Responsible Officer for Power of Communities, and I run a charity in Bradford. You mentioned the power of working with local communities and local VCSE organisations, and I think it's worth flagging, linked to some of the things we've discussed as a partnership earlier, around the early help and prevention, and the hope everybody around this virtual table's got their fingers and toes crossed that that we'll be able to return to early help and prevention. But I think we have to be real in this partnership about the hit that work has taken of late, and that the VCSE have seen that very, very heavily. So you've mentioned it in terms of cancer, but it's relevant to lots of different pathways, that we rely a lot on the local infrastructure that sits in localities in particular that we know is valuable. So those community anchor organisations that link into integrated neighbourhood teams, and the work that we're doing in health as well, the VCSE infrastructure. Now, community champions is a really important example of that, which I know that a lot of people have seen work very well in their place. Those things are either being decommissioned or have been decommissioned already, or have taken very, very high percentage cuts. So I think it's just worth flagging that we need those infrastructure in order to reach those diverse communities. We also need the grassroots organisations that are reaching the diverse communities, and cannot now make the assumption that those organisations are going to be there or able to engage in any of this work due to decisions that nobody has wanted to make around this table. But that is the reality of where we are. So I think we need to sort of take a pause and think through what sits in our localities in terms of infrastructure to enable this vital work and other vital work, and take a little pause before we lose things that we're going to live to regret many years down the line.
Yes, I think we'll probably both separately answer that point, Kim. Just from my own personal point of view, indeed, kind of perspective from the cancer community in West Yorkshire. I largely agree with that kind of comment. In reality, the voluntary social enterprise sector has a huge role to play in terms of delivering effective point-to-point, end-to-end care for people affected by cancer, their families and carers. And I think actually we mustn't recognise the fact is that, yes, the performance standards look at the form performance, the NHS and the acute system, which is very important. But as I said, the experience of cancer will start for somebody from when they first experience symptoms. And it will be a significant journey after that, which have profound impacts in their lives. And indeed, actually, the way in which we address that is we actually address the whole system. We actually work together on that. You make some, really valid points in terms of actually us not assuming that those facilities and structure are in place and recognising that indeed, if they change, that will have an impact on people affected by cancer, indeed, other long-term conditions too. I would say is that what we do try and do is we have an innovation competition each year, so where we can directly fund VCC organisations directly relevant, such as, those I talked about living beyond cancer and some of the prevention, and do offer some direct funding. It's not significant because it's based on the resources we have as a system. However, we do try and deliver some of that work directly to make a difference, and it's something we're really proud to continue to do. Helen.
I think also, Jason, thank you. The learning that we have, innovation competitions, we should share because a lot of these ideas are scalable. So I think we do need to be really careful to support the scarce resource that's out there from the VSO.
Yep.
Okay, thank you very much. That concludes everybody with questions or comments on that item. So thank you for your time and for the detail in the presentation. I hope you also gained some useful things to follow up from there on both sides. Thank you.
We did, thank you.
Thank you.
Thank you. So we have one substantive item left. I'm going to suggest, obviously, change slightly the order of the agenda. I'm going to suggest that we do have a 10-minute comfort break so that people can concentrate and focus on the last item, which is also an important and interesting one. So I suggest that we start again at 10 past, if that's okay with people. Thank you. So welcome back, everybody. The last two items on the agenda, the patient and public voice item is being included within item 8, which is about our ambition to reduce the gap in life expectancy between people with mental health conditions, learning difficulties and or autism and the rest of the population. I'm going to invite Keir Shilliker and Emma Pearce to introduce this item. So over to you.
Thanks, Chair. So hi, everybody. For those who don't know, my name is Keir. So I'm the Programme Director for Mental Health, Learning Disability and Autism across West Yorkshire. And I'll ask Emma to introduce herself as well.
Afternoon, everybody. Emma Pearce, Consultant in Public Health for the West Yorkshire Mental Health, Learning Disability and Autism Programme.
Thanks, Emma, and thanks, Chair, for that brief intro. So yes, absolutely, as described, the focus of this session is about that system ambition and the aim to reduce the gap in life expectancy for the population that we serve across our sector for people with mental health conditions, learning disability and autism, recognising that there is a gap in life expectancy for that population against the rest of our population. And roughly speaking, we know that gap is anywhere between kind of 10 and 20 years in terms of life expectancy for the people that we serve. And we also know that, broadly speaking, that gap is actually increasing. And as well, within that number, about 2 out of every 3 deaths that do occur are from those conditions that we regard as preventable. So those things that we've talked about previously around cancer, respiratory conditions, cardiac conditions, and as well people who die by suicide. So there are significant opportunities to do more to support the population cohort that we're talking about. So the paper that we've circulated outlines some of the detail around the kind of 5 key metrics that we're using to tell us if we're making progress on those things that contribute to early death. And it's worth emphasising that these are essentially proxy measures. There isn't really a universal way of capturing and describing a single metric or a single way of understanding if we're kind of delivering against those ambitions. But what we're trying to look at is the kind of the holistic impact of things like the impact of ethnicity, the impact of smoking, the availability of health checks for that population cohort, and those wider determinants around employment and housing, and the real impact that they can make to people's lives that reduce the chances of them dying earlier than we want them to. So rather than dive into the depths of the paper, because recognising that is there and there's a lot of data in it, and people are more than happy to kind of interrogate it and ask us questions after. What Emma's going to do is do a bit of a brief presentation that shares what we know about people's experiences of those focus areas too. Some of it's local intelligence, some of it is national, but hopefully by sharing some of those experiences alongside the data that's in the paper itself, we'll get a full sense of how important this is as a focus area. And then at the end, we'll just do a bit of a summary of our ask of the board and partners about how we reflect on what we've heard today and what we expect or ask for in terms of actions and focus locally. So I'll stop my little bit of introduction there and ask Emma to come in with the slides, if that's okay.
Yeah, lovely. Thank you, Keir. I'm just going to share those slides. Remember to click the include sound button as well, so hopefully that works for people when we get to those bits. Can I just confirm that people can see those?
Yeah, I can see Emma.
Yes, thank you.
Thank you. There we go. So as Keir's explained, our focus for this session is really looking at not only how to reduce premature mortality for our MHLDA populations, but why it's important and why it's important to them. And I really just want to start by saying a big thank you to the populations across West Yorkshire that have fed into some of this work, and to Healthwatch colleagues who've been absolutely instrumental in helping me pull this together and kind of turn it into something that allows us to talk about people's experiences. So just as a starter for 10, we absolutely cannot separate mental health from physical health. You know, they are two sides of the same coin. And things that really play a crucial role in our ability to reduce that premature mortality are prevention, early intervention, and a focus on health inequalities. It's just important to keep all of that in mind. Thank you, Kathy, for explaining my acronym there as well. I also wanted to say that this is a partnership effort, so it absolutely cannot be achieved by one programme alone. So where in the paper we've described what we're doing as a system team and what we know our place colleagues who work in mental health learning disabilities and neurodiversity are doing, it absolutely relies on all of those interactions. We've just heard recently from Jason and Helena in the Cancer Alliance, and Jen's question around screening and LD. So, you know, all of these interactions are all there. And so I'm just going to briefly talk through our 5 metrics and kind of show you the impact that we think we might be having. Metric is all around recording and understanding the impact of ethnicity on mental health learning disability and autism services. This is just a small selection of the comments that we've had through a number of different Healthwatch reports and others, where people have really reflected on their experiences of being part of a racialised community and trying to access mental health services. And what we really see is that there are barrier upon barrier upon barrier that people are facing. And so it's really important for us to be able to record people's ethnic background, record people's race, also record factors that are linked to that, such as religion, culture, and other kind of factors that describe that person as a whole, not just as, you know, pinholing them as a single ethnicity, so that we know who they are and where they are. And then when we understand that better, we can start to target our services and target our interventions towards them. You'll also see in the paper that we talk a lot about the NHS England patient and carer race equality framework. We've got a huge amount of work planned around that in the coming year. We've also got our cultural competency and humility training package that's in place, that's being rolled out across a number of organisations and places, all aiming to kind of support people from racialised communities in accessing our services and get rid of these comments. What I'd like to see is that in a few years' time, people are not saying these things about our services, but they are saying they are welcoming services. They are services that speak to me. They are services that I want to access. Our second metric is around reducing smoking rates. And just as a starter for 10, half of all deaths in people with a serious mental illness, SMI, are attributable to smoking. That's just 15% of all deaths for people in the general population. So as we can see, if we can tackle smoking in that population, we can make a huge impact on the gap in life expectancy. The Royal College of Psychiatry and all of their kind of partners within this have got a quality improvement programme up and running around inpatient smoking cessation services for mental health. Some of these quotes are from a recent national evaluation of those services. And one of the things that I'd like to add to this is, whilst these quotes aren't directly relevant to our services, one of our trusts has recently signed up to be a member of that quality improvement programme. And so what we're going to do going forward is make sure that we share that learning across, bring in as much of the national intelligence as we can, and start to look locally as well, and really talk to our service users, our carers, and understand what smoking means to them and what smoking cessation means to them, and how we can support them to access the services that we're putting in place. This is the first bit of sound, so fingers crossed that it works. I just wanted to start off by playing Sarah's experience, and Sarah is one of our learning disability champions across the partnership.
Yeah, it's difficult sometimes to get an appointment, but the receptionists at the doctors are really good with me. They ring me up when I'm due to blood tests or annual health check, hopefully. They call me when I need to book appointments. They're amazing.
It's a very, very brief clip, but I think what it really highlights for me is that Sarah is absolutely dependent on that good relationship with primary care to get her annual health check booked. And we know that for people with learning disabilities, the annual health check is one of the most important preventative interventions that we can support them to access. So it's really highlighting the role of place, the role of primary care. And, you know, we've talked today, we've heard from Brian about the pressures that primary care are under. So I don't want us to sort of lose sight on how difficult it's going to be to keep improving the number of people that get to access these annual health checks, but they are so important, and people value the relationship that they have with their general practice when they're trying to access these. We also know that when we look at our leader reports, so these are selected reviews of people who have passed away, but also have a learning disability, we can see that whilst we're not too bad at completing annual health checks for people in the year prior to their death, we're not doing it and recording it in 100% of cases. And actually that makes me nervous. It makes me start to wonder, did we miss something for this person? Was there something that could have been picked up in that annual health check that we were unable to tackle for them? So it's one of the kind of core metrics that we're really looking at, is bringing together the learning from leader and the aiming for the NHS England target, if you like, and making sure that we're understanding why we're doing these annual health checks. The other thing just to flag here as well is that the national leader report for 22-23, and I've just brought this up rather than our local one because our local data agrees, but this is, we've got bigger numbers here, so it's just a bit more impactful. The vast majority of causes on that table, causes of death, are things that we can see in an annual health check, and they are things that we can intervene in early. You know, if you look at leading causes of death in 2022, you've got malignant neoplasms, so we've talked again about cancer. You've got influenza and pneumonia. Well, actually, vaccinations are an incredibly important intervention there. And are we using our annual health checks to make sure people are accessing their vaccinations? Ischemic heart disease as well is contributing to a huge number of those premature deaths. So we've got the intelligence there. There's detail in the paper around what we're actually doing with it, but just to really bring some of that to life.
Yeah.
Our fourth metric is a very similar one, so it's around physical health checks for people with serious mental illness. The box there highlights again why we do those physical health checks for people on an annual basis and what the importance of them is. Those increased risks of diseases that are directly attributable to having a serious mental illness, and often it's the medications that you take as well as the impact of disease on your life and your lifestyle and your ability to have the same opportunities that other people who don't have a serious mental illness have. All of those things can be picked up in a preventative way through early intervention by supporting people to access their physical health checks. The quotes here are not local. We don't have that much local insight into what people think about physical health checks, but we do have the Equally Well UK group, which really kind of champions that joining together of physical and mental health. And this is from a blog from an expert by experience who's talking about her experience of physical health checks, the good and the bad. So, she's experienced things where appointment times are tailored to suit her. She's been familiarised with annual health checks before she's been kind of walked through the process, so she understands what's going on. But equally, there were some issues there around discharge from hospital or links with primary care. So all of this is really important intelligence that we can draw on locally. And again, there are some excellent examples in the paper of areas where we are doing this already. Our final metric is, as Keir kind of pointed out, more linked to the wider determinants. So we're talking about providing safe housing and meaningful employment. I've got another audio clip here. It's a few minutes long, but what I'll do is sort of start you off, play the beginning of it, and we'll see how we go. Apologies if you can see my YouTube history in the sidebar when I open this up.
Sophia, September 2022. How does your mental health impact your employment?
I'm self-employed, so you just have to take work when you get it. And then the worry is for me is like if I mess it up, because like my mental health gets bad, and it's like it can be really unpredictable and I can't always foresee when that's going to happen. So yeah, that's quite stressful. Obviously, I was meant to do a big job over the summer. That was like a lot of income, like it would have really sorted me out for quite a while. But I had to basically break my contract because I was too unwell to participate, and so I basically just burnt a load of bridges. That caused a lot of stress. Yeah, it caused a lot of stress. I didn't even know how to like tell them what was going on because I didn't even know what was going on. And then like luckily the psychiatric like decisions like unit, they helped me like write the email to them because I couldn't even like put together a sentence. Like my brain was just mush. I was just like, I don't know what to do with this. It was rough because it was quite embarrassing for that to happen because obviously it was happening at the job as well. Not all employees are going to be, or employers are going to be flexible about that kind of situation or be able to understand it, because it's really difficult to, if you don't know someone really well, it's hard to notice when somebody's being an arsehole or when they're becoming really unwell.
Are you working at the moment?
Like at the minute I'm not working because literally my friends just like do not work. Like any stress is just going to trigger another episode of this. But then it's really hard to not work because obviously like money, and also like you just feel like you're failing because then you're not doing anything. From work, like you're engaging with people, you're meeting new people, you're working with colleagues, friends, you're going to places, like travel around to places, and like it can be fun. I mean, also it can be tedious, but it can also be really fun. And like by going to work, you also gain more work, especially as a freelancer, because like word of mouth is probably the biggest advertisement for you. So by going to work and being like active in the community, then other people will be like, oh yeah, do you know anybody who does? And then somebody else will like volunteer your name. So by basically just disappearing off the face of the earth, it's going to be harder when I do start working to get the work again. It'll take a bit of time.
I'll pause there. So that was the words of Sophia, who's a a resident in Leeds, and I think really just brings to life the importance of that link between work and mental health for me, and how empowering it can be to work, but also how distressing it can be to try and continue working whilst you feel that your mental health is not where it needs to be. We've got a couple of other quotes there from Health Watch reports, again, about, you know, the good and the bad of working whilst you've got poor mental health. And I think a lot of those quotes will also apply to people with learning disabilities and neurodiversity as well. And really, we want to focus on safe housing and meaningful employment because of that link, as we sort of discussed slightly earlier, to poverty. So if you've not got a safe, secure, means of employment, if somebody is not paying you that real living wage, you're not able to afford a safe, secure place to live. And then you've got this cycle going on where things are just not improving for you. You're living in a cycle of socioeconomic deprivation. And as we all know, that equally impacts on premature mortality, reduced healthy life expectancy, and reduced life expectancy. So these things are so intimately and intricately linked that we felt it was, we needed to put that in there as a metric, although, as you can see, it's a difficult one to measure, particularly within the paper. You can see it's a difficult one for us to measure, but we're absolutely dedicated to recognising the link between the wider determinants and reducing that gap in healthy life expectancy and life expectancy overall. Here, shall I hand back to you to do the little summary?
Thanks, Emma, and thanks for running through that. It's massively helpful. I think kind of just as a summary at the end, what we've tried to detail both within the paper and within the reflections of people's experiences, it is about that significant complexity and cross-organisational input and impact that will deliver the ambition to reduce the gap in life expectancy. There is plenty of work happening in places and providers and across the system that contributes, but as ever, there's always more that we can do. And some of it is about service delivery, some of it is about prevention, and some of it is about utilising our collective expertise as an integrated care system to understand that impact better. How do we report on it better? How do we track it better? Can we utilise kind of the infrastructure we've got to get better at knowing if we're making a difference? Because it is difficult, and Emma outlined there, particularly around the kind of the wider determinant stuff, we're making some broad assumptions. And they're sensible assumptions, but they're still assumptions around kind of the impact that we're able to see. So I think the final messages are around how do we recognise that importance of the physical health, mental health interface, that importance as ever, particularly in the mental health, learning disability, neurodiversity sector, of prevention where possible, or early intervention where possible. The importance of what wider determinants, which stray way beyond healthcare and way beyond care and into kind of wider society and wider life for people at large. And then, and really importantly, the significant impact of inequalities that the population that we serve faces across the board. So, if you're somebody who suffers from a mental health problem, but also have other elements of inequality, that life expectancy is inevitably going to be really challenged. And what more can we do? So, yeah, a question really about, it's not just something for our mental health, learning disability and autism sector to consider, not just something for the ICS partnership to consider, but also how do we ensure that these conversations happen in our places, and those metrics we've outlined as well, are the visibility of those in our places too? Are there sorts of things that are regularly talked about in terms of the impact we're trying to see for our population? So, yeah, they're kind of the questions and a bit of a poser from us, I guess, but I really appreciate the time to share, and thanks, Emma, for running through, but I'll stop there. That's okay, Chair.
Okay, thank you very much. Some questions and comments, starting with Fiona.
Thank you. Thank you so much for your presentation and your paper. I'm really passionate about this issue. Before I was a full-time counsellor, I was the Chief Executive at Leeds Survival and Crisis Service, which provides out-of-hours crisis support. And if you visited Dial House, the crisis house they run at night, you would get a really clear picture just by looking around of why people with mental health problems are dying earlier. 90 to 100% of our visitors smoked, and that really isn't an exaggeration. also huge rates of obesity and lots of long-term conditions, you know, COPD, asthma, diabetes. The 15 years that I led that organisation, I went to a lot of funerals that were people who died in their 60s from heart failure and other associated conditions. I've got a few comments. So around smoking, Leeds is doing some really great work on this. There's a smoking cessation programme run by Public Health that goes into the inpatient units at LYPFT, which is great because obviously people are there usually for a lot longer than if they were in LTHT. So you do get to work with people for a while, but also the follow-up in the community is really, really important. So any work that the NHS is doing around this really does need to be linked with public health teams in the individual places. Ditto obesity. I think it's really horrifying that, you know, 2/3 of people in Leeds are overweight. That's like most people, and that's obviously a statistic that's replicated nationally. And I think we'll come to look back on this time the way we now look back on smoking and think, why was society so permissive? But actually, similarly, there's loads of really fantastic work that public health are doing, but it has to be a really systemic approach. And I wondered if you'd looked into any of the work that's happening around licensing and planning. So there's some councils that have made decisions that on their billboards, they won't advertise high salt and high sugar foods, for example. In Hare Hills, which is the most deprived ward in Leeds, we've got a cumulative impact assessment, which means you can't now open another off-licence or another takeaway outlet in that area. So again, there's loads of kind of work with a number of council departments. I wanted to raise the issue of which wasn't really mentioned in the paper about primary care, and the fact that in my experience, and this is my experience using services as well as running them, if you've got mental health problems, if you've got diagnosed mental health problems, it's really not an uncommon experience that your physical health needs get kind of marginalised, and physical symptoms are sometimes attributed to mental health issues. The most extreme example of this that I heard from someone when I worked at Leeds Survival-Led Crisis Service was someone who was having heart problems, and it was put down to anxiety by the GP because they were having chest pains, and they also suffered from panic attacks because they had anxiety. So I think that's a really significant issue, actually, that particularly if you've got a serious long-term mental illness, that kind of subsumes everything else, and physical health can get really overlooked. And then I also think there's, particularly with some of the older antipsychotics, some of which aren't even prescribed anymore, there's also the iatrogenic impact of taking medication for a long time. Finally, I just wanted to make a point about the wider determinants that if we're looking at housing, we really need to be engaging with the private sector, because that is now where most people live. So in Leeds, it's our biggest housing sector, where it used to be council housing. And that's also the sector that has the most detrimental impact on both physical and mental health. So obviously you've got all the respiratory stuff with damp and mould, but it's also the sector that's most likely to cause you mental distress in terms of affordability and quality and security of tenure. So I think it's really impossible to do work around healthy housing without engagement with the private sector and looking at things like selective licensing, which we've done in Leeds, which we're still doing in Leeds, which is about raising the quality of private sector housing. Okay, I'll stop there because I know other people want to come in, but thank you.
Thanks, Fiona. Kim, it's okay. I'll take people in batches and then just see if there's anything you want to comment on, if that's okay. Kim, can I come to you next?
Thank you. I'm going to speak here with my Stella Trust hat on, if that's okay. We've been delivering mental health support to people with severe mental illness for over 35 years, not me personally for over 35 years. And almost all of our workforce are people with their own lived experience of mental health problems, including severe mental illness. So that's the learning that we've got. My plea is, I think, to the people on the call that there's much more opportunity for integrated service provision around employment support. The way that the national policy is set around mental health and employment support by NHS England keeps it quite specifically in terms of very prescriptive models that sit primarily within health settings, so community mental health teams or NHS talking therapies, which is great. And, you know, we've got examples across West Yorkshire where VCSE are involved with delivering those. However, our experience is that most people who come for employment support cannot go back into employment because they're experiencing multiple other issues covering everything from housing to poverty to domestic abuse to just not being able to feed their family. So nobody is interested in looking for a job if they can't feed their family, or they can't get other access to support for their severe mental illness because because of the demands elsewhere in mental health services. So all those other wider determinant things sit in other people's commission. So I think we've got a really good opportunity in West Yorkshire, speaking to Rob's point about high level of autonomy but high level of accountability, to see what is within the art of the possible, I suppose, to challenge back where the national models don't necessarily work for our populations, but also to be really creative about the money that we do have, and look at the models for delivery. I'd point again to sort of integrated neighbourhood teams, locality-based working, to see where are there some opportunities for some pilots for more closely working together on the employment agenda.
Thanks, Kim. I'll bring Jen in and then just check if there's anything here or Emma want to pick up on. Jen.
By chance, you've teed that up really nicely, Kim, for the point I was going to make as well. So firstly, on the housing, it's referenced in, it wasn't particularly mentioned here, but it's referenced in the report, the work that's been done around the needs assessment, and just wanted to really welcome that work and note that has been picked up through the West Yorkshire housing strategy under the second objective in that housing strategy. So really welcome that, and it's great to see that connection, as Fiona and others have referenced. Lots more to do, but just to say that has been really welcomed. Then in respect of work, we've got a West Yorkshire Work and Health partnership, and that's really been established to support the system in better working together on this agenda, and that's got a real drive on inequality. So some of the programmes like IPS, the programme that's mentioned in the report, we've got excellent kind of results from that in West Yorkshire. We want to better connect this work. I've invited Keir or Emma and Emma's maternity leave cover to come and join that partnership, so that we can just really look at that join up. And Kim really welcome your suggestion about how we kind of, what the delivery of that looks like, how that needs to look differently. We are also about to look to get some further insight from our communities about how we better do this as well. We'll be putting something out and get that work done over the next few months, and then develop a work health and skills kind of strategic framework, which will be across West Yorkshire, but we'll have that focus on inequality. So particularly want to ensure that we've got the mental health, learning disability and autism agenda right in that. Thank you.
Thank you. Keir, Emma, anything of those you want to respond to before I bring some more in?
Thanks. I'll just come in with a quick thought, Emma, and then jump in after me, if that's all right. So a couple of reflections. I think to Councillor Venner's point, particularly the bits around licensing, or kind of the rules around kind of what can go where from a planning perspective. Kind of back in a previous life, and before I moved back to West Yorkshire, I did a lot of work nationally on something called Healthy New Towns, which is an NHS England initiative, and that was trying to look at what the rules of the game should be for creating healthy communities. And that's at the time when Simon Stevens was really, really hot on the issues of, where do we put things that can damage the nation's health? And I think, looking at that more broadly would be really, really helpful. And then a bit about employment, your point, Kim, and as we know, and Jen's touched on it, the NHS England focus is absolutely, from an employment point of view, quite rigid and quite narrow. It is around individual placement and support as the model that supports people into employment. And it's really important. And as Jen said, it really, really works. And there is dedicated funding for it that is expected to be utilised this year to deliver certain access targets across the system. But there are opportunities within the wider community mental health transformation agenda, the integrated neighbourhood teams agenda, to go, actually, what can we do differently and more creatively? And some of our third sector partners in the past frustratingly have had to almost change their model a little bit to become more IPS-y and less holistic, just as a result of how the funding flows. So trying to move back to kind of that, the opportunities for doing things differently is there for us, I think, and actually within the financial constraints we've got, might be more important now than it would have been previously as well, I think. So yeah, just a couple of reflections from me, but I'll ask Emma if there's anything to add.
Yeah, just one thing for Councillor Benner, I think, just to reassure you that we are working very closely with public health teams across all 5 places. So myself, Jen from the Combined Authority, Sarah Smith as the AD for Improving Population Health. We meet with our Directors of Public Health on a monthly basis and really make sure that we're kind of crafting a West Yorkshire vision for where we think the big public health priorities need to be. So anything like that we can that needs to be brought up and we discuss, we do so on a regular basis.
Okay, thank you. Okay, I've got 3 more people who want to come in, so I'll start off with Sean.
Yeah, thank you. Sean Rayner from Swift. I'm representing Mark Brooks today. Both in the paper and in your presentation, Emma, you reference concerted partnership working, and that is very true of the 3 West Yorkshire districts we work with partners in. And I think for the health checks, certainly for people with learning disabilities and the SMI health checks, that question you had here about the metrics has been the right one, so percentage numbers. But I think as we move forward, we're very much working in partnership and with our public health teams around the so what question, really. So what's the quality of the health action plan showing, and how much more do we need to do to ensure that those action plans address the very points you raised in the presentation, Emma, and in the paper about the inequalities in access, in life, number of quality life years, etc. So yes, it is a concerted partnership effort, and I do think there's a point about going beyond the percentage metrics that we have now to look at the qualitative impact going forward. So thank you.
Thank you. Fatima.
So we've heard quite a lot about the importance of the wider determinants of health in this space, and the Mayor of West Yorkshire, Tracy Brabin, is absolutely committed when she talks about putting more money in people's pockets. But I would argue that that isn't enough, because we live in a society that is unequal. And we've heard a lot about the wider determinants, but we've not really explored the concept of social justice and how that impacts people's mental health and well-being. And there's a lot of work in this report here that nods towards that. But I'm wondering whether there's more that we could do. So in the context of sort of poverty, while that's really, really important, we do know that people dependent on their sexual orientation are massively disproportionately impacted with their mental health and well-being. We also know that children in care have a massive disproportionate impact when it comes to their mental health and well-being. But if you look at it through the lens of intersectionality, if you're a woman and you're from a different ethnically diverse background, that again, disproportionately increases. So I suppose my offer is, how can we harness the opportunity of working alongside the Combined Authority and its local growth plan to really harness not only putting more money in people's pockets, but whose pockets, because that will improve people's prospects and therefore hopefully support some of the manifestations of this. But also, more importantly, how do we support people at the coalface delivering this to do it in a personalised and inclusive way? So I can see Helen Hurst in the centre of my screen, and she always catches my eye when she's on a call. But I remember when we used to talk about health checks, when I used to lead the personalised care programme, and she used to argue, well, that's really good that they've got a health check, but how good was it? Did we hit the target and miss the point? Or did we actually deliver what we aspired to do? So I think there is something about ensuring that when we're thinking about these things and these metrics, that the metrics deliver the aspiration behind it. And I think there's also an opportunity for us to really harness the power of the EDI strategy that we're developing for the ICB to really move into the realms of social justice, because the engagement and conversations we've had so far are about, actually, we know what the problems are, but what we need to do is address some of the manifestations or causes of the problems in the first place. And part of that are the societal embedded advantages within our organisations, the way in which we deliver and design services that are disproportionately giving these people a not so great experience and not enabling them to fulfil their potential, such as going to work.
Thank you, Fatima. Susan.
Thanks, Chair. Two things. One, does the serious mental illness, does that include like dementia, particularly early onset dementia? There's a lot of people now getting dementia in their 50s, and I have the same worry for them actually about accessing health checks when, you know, it's hard organising yourself. So that's one thing. The other thing is, obviously employment comes up in here, and I was struck by the representation you had in your presentation from that person who'd struggled to do that contract she had. The workplace is very, very hard, isn't it, these days? It's a high pressure workplace wherever you are these days. And have we got, and there's all sorts of vulnerable groups that we're all trying to support into employment. And I just wonder if there's something we need to do about, is there any work that's going across West Yorkshire, for example, it's saying what an appropriate workplace is for somebody who's vulnerable, and how we can sort of work with employers, including the employers in this virtual room, really, to make sure appropriate work placements are there for people. I say we're all doing it for different groups, but you know, we've got Bradford and your figures at 8% employment. It's not very good, is it, really? So we need to do better. And by the way, I think this is a very good, thoughtful presentation, so thank you very much.
Thanks, Susan. Just finally bring Kathy in and then come back to you. Kathy.
Thank you. I suppose what I wanted to do was try and pick up a number of themes from our discussion today. What can we do as a partnership? I know when we come out of these meetings, we think, what's the one thing, or what's the three things I can do as collectively as well as individual leaders? So smoking cessation has come up quite a lot through our discussions today. And I'd really welcome Keir and Emma alongside our public health colleagues, just following up after this meeting on what's the one thing you can do, and here's some examples of best practice that people can then go back into their own work and their own organisations to see if that is the best practice they can offer. We've also talked about health checks there and the quality of them. So I'd really, my ask to the team in putting the meeting together today, I think just a summary of what 1 to 3 things colleagues could do out of this meeting. But I'd say smoking cessation seems to be a theme for the whole of this meeting today.
Thank you. Kate, can I bring you in?
So thank you, Councillor. Just a very, very quick one from me. It was just to reply to Councillor Hinchcliffe's point, perhaps an offer that I could take that away to the West Yorkshire People Board. I think really what we were talking about there was supportive workplace and some of the workplace principles. I already work with some of Keir's team around inclusive employment and how to make that much more effective. So I think between 1 or 2 of those groups, we could perhaps offer to take that away and sort of look to develop something collectively, as you say, between us is the key.
Thanks for Kate. That's really helpful. So, Keir and Emma, any final reflections from yourselves?
Just one, if I may, please, Councillor Swift. Just on the metrics, you know, we've heard today kind of, are we, you know, hitting the target but missing the point kind of thing. I just want to reassure people that although the metrics that we're using sometimes seem a bit, you know, process and performance heavy, they are the things that we can measure in the current system that we are working in, but they are absolutely not our end point. They are merely a sort of a starter for 10 for us, and we're absolutely, you know, invested in getting the outcomes for people right and understanding the experiences and the impact, but recognising that we do have to provide some numbers at some points.
Thank you. Keir, anything you want to add?
I mean, we must be in lockstep because Emma basically said better what I was. So I'll leave it there.
Okay, well, thank you very much for.
Okay, just ask a question about dementia. Sorry.
Oh, sorry. Yeah.
With regards to the health checks, so so dementia won't come under the SMI definition for a health check. So people will either have to wait until they sort of get called up with the general physical health checks that are offered to adults over 40, or if they are taking an antipsychotic for their dementia, they will be on the health check register. So it's that serious mental illness for the purpose of health checks has a very, very narrow definition that just covers psychosis, severe depression and bipolar disorder.
Thank you. It's an interesting point, though, about where people with early onset dementia fit into some of these things, and perhaps one colleagues will want to pick up and come back to you on, Susan. Well, look, thank you very much, Keir and Emma, for that presentation. I hope it was quite a bit of it, and thank you, Kathy, for that suggestion about picking up the key things we can take forward. I think there was an awful lot in there, and certainly I think the point about smoking cessation, which came through both of them, hopefully we'll see in the King's speech tomorrow a commitment to reintroducing the legislation, and also ongoing certainty about the funding behind those activities as well. Thank you. That is the final item on our agenda for today. So thank you very much, everybody, for your time and contribution. We seem to, between the two sessions, we seem to have covered an awful lot of ground, and I hope people have found it valuable. And thank you to the team from the partnership for the work that's gone into organising today's meeting. And I hope everybody has a good evening. Thank you.